Cancer series of our pediatric webinar series. And this is on the follow-up care for adult survivors of childhood cancer. And I want to introduce and thank Kyla Alsman for being here and talking to us. She is what's called a survivorship transition navigator. And she works for not only in the survivorship transition clinic at KU, but also in Survive and Thrive at Children's Mercy. So she can kind of hold hands to transition somebody from care over from Children's Mercy into KU as they become adults. So the way we'll do this, Kyla will give the presentation. If you have questions along the way, feel free to put them in chat. If there's something that, I feel like we need to answer before you can understand her progressing, I'll stop her. Otherwise, we'll wait till the end and do all the questions at the end. But Kyla, thank you for being here, and I will turn it over to you.
All right, thanks, guys. Today, I'm going to go over and discuss the follow-up care for adult survivors of childhood cancer. I'm the nurse navigator. Oh, can you hear me? Or I'm hearing an echo.
With the left side of my screen, and we'll let folks continue to
Tony,
hop on.
are you able to mute? I think that's background noise from you. Thanks.
Okay. All right. Like Kathy said, I am the nurse navigator for the Survivorship Clinic here at KU and also for the Survive and Thrive Clinic at Children's Mercy. The Survivorship Clinic was developed back in 2014 in collaboration with Children's Mercy to help with that transition of childhood cancer survivors as they aged out of the children's facility. I work closely with Dr. Becky Lowry, who's an internal medicine physician and the medical director for the Survivorship Transition Clinic at KU. And then at Children's Mercy, work closely with Dr. Joy Fulbright, who's an oncologist at the Survive and Thrive Clinic. After today's presentation, you should be able to answer, why do we need to talk about this? What are late effects and who are at risk for them? And what resources are available to help when providing care for these patients? You may ask yourself, why do we need to talk about adult survivors of childhood cancer? Haven't they already beat cancer? There's several reasons this topic has been one of growing importance. The first reason is the prevalence of the patients impacted. As you can see in the graph, survival rates for cancers have continued to increase over the years. While this is exciting, we also need to think about these patients long-term and develop a plan to help them understand their risk. It's important to educate them on ways to minimize the risk and what screenings they need to continue to complete. It is expected that the number of survivors will continue to grow to more than 22.1 million by 2030. And one may ask, who is a survivor? Survivorship is defined as anyone who has ever had cancer from the time of diagnosis for the rest of their life. When we look specifically at childhood cancer itself, it's estimated that 1 in every 530 young adults aged 20 to 39 is a childhood cancer survivor. Childhood cancer consists of multiple different types of cancers, as you can see in the graph. The most prevalent ones are ALL, which is acute lymphoblastic leukemia, and all the different types of brain tumors and CNS tumors. Now, the second reason this is important is that while the number of survivors are growing, the number of providers who have traditionally provided their care is not growing, and there will be a shortage of oncologists. So we need to think about who will care for these survivors. We know that these survivors no longer have active disease, so does it need to be an oncologist? The question then becomes, where should survivors receive long-term follow-up care? We know that oncology visits tend to decrease after 5 years of treatment due to the decline in the risk for relapse. We also know that patients expect both their oncologists and their primary care providers to be involved in their survivorship care. So where is the right place for them to receive care? Can primary care providers take over? Some suggest survivorship care should be provided in these survivorship clinics, similar to ours here at KU and Children's Mercy. However, there's not a lot of these dedicated survivorship clinics for adult survivors of childhood cancer. Most of them are located in children's facilities, and they eventually age out. So it really highlights how important primary care is already, and certainly highlights how primary care could help with providing the care for these patients. If primary care providers do provide the care for these patients, we also need to think about the knowledge. Are they familiar with the risk related to the treatments these individuals receive? Do they know the screening recommendations? We know from the literature that there is a knowledge gap around providing care for these patients, not only to the primary care, but also to the oncologists. For many actively practicing, there was a training gap. The training as survivorship care was not part of their curriculum. The literature has started to highlight this more over the last several years. In 2010, in the Journal of Clinical Oncology, there was an article published about the study around knowledge and preference from pediatric oncology physicians. When they were presented with a clinical vignette of a female survivor of Hodgkin's lymphoma, we know that these patients often receive mantle radiation and chemotherapy as part of their treatment. Oncologists were not familiar with the recommendations to start breast cancer screenings at age 25 or 8 years after radiation due to the increased risk for breast cancer after receiving that mantle radiation. They also were not familiar with the recommendation for cardiac screening, which typically is every 2 to 5 years, or the recommendation to start doing thyroid screening yearly due to the impact that it could have to the thyroid. Oncologists stated they were most comfortable caring for patients less than 21 and less comfortable with caring for patients 21 to 30 and uncomfortable at age over 30. There's also several similar studies done to look at primary care providers providing the care for these patients. What they found that while these patients were being followed in their clinics, providers also described discomfort with providing the care similar to the oncologist. So you may ask, what is survivorship care and what are the late effects? What do we need to continue to monitor for? Survivorship care is risk-based care that is specific to the patient's past treatment and oncology diagnosis. Late effects can be both physical or psychosocial and may not develop until years after treatment has occurred. Late effects may also resolve or become chronic problems. 3 out of every 4 childhood cancer survivors will develop at least one survivorship-related health problem. So let's look at late effects. Late effects, like so many things we see in the medical world, late effects really develop from not one, but a combination of factors, including the type of cancer, the location of the cancer, the treatment they received. Did they receive chemo, radiation, or a bone marrow transplant? One's genetics can also play a role in late effects. But there are still things we have control over and lifestyle choices we can make to minimize our risk. While we do not fully understand why some survivors experience more severe late effects than others, what we do know is that caring for childhood cancer survivors requires knowing details about their cancer type, their cancer treatment, their comorbidities, health behaviors, and the things they need to be assessed with each survivor. So let's break down and dig a bit deeper. First, we'll look at the tumor facts and how the tumor itself can impact the risk. This is an example of how a tumor type impacts late effects. A typical patient with a Wilms tumor localized to the kidney will undergo the surgical removal of the kidney, known as a nephrectomy, and receive a minimum amount of chemotherapy since it typically responds pretty well to therapy. This patient would not require any radiation. On the other hand, when we look at a patient with a medulloblastoma, they typically undergo a surgical resection of the tumor, which often has more quality life-altering effects than a nephrectomy, given the location. The medulloblastoma patient also requires more extensive chemotherapy with more toxic high doses. The patient will also receive radiation. Given all of this, the patient with medulloblastoma would be expected to have a much higher risk of late effects and potential health problems compared to the Wilms tumor due to the location and the type of treatment they received. Next, we will look at treatment factors that vary. When we think about late effects, we know that each chemo agent has a different side effect profile. Some of the main chemotherapy agents we use include anthracyclines, such as daunorubicin or doxorubicin. Many also call it the red devil. Anthracyclines can cause cardiomyopathy that may not occur until years after treatment, which is why it's important to continue cardiac monitoring with echocardiograms lifelong. Methotrexates and steroids decrease bone mineral density. We educate our patients on the importance of vitamin D, calcium, and weight-bearing exercises to minimize their risk. Bleomycin and busulfans are another type of chemotherapy that can cause damage to the lungs, leading to pulmonary fibrosis. As you can see, each different type of chemo has different risk, which was why it's important our patients are aware of the types of chemo they received and the risk that they are at risk, the things that they're at risk for. So beyond the type of chemotherapy agent, the dose also plays a large role in the survivorship risk of developing late effects. This graph was published in the Journal of Clinical Oncology in 2010, demonstrates that while no dose of anthracycline is completely safe, there is a definite correlation between the amount of anthracyclines a patient receives and the risk of developing cardiac late effects. You can tell by the graph that individuals who receive greater than 250 milligrams per meter squared of an anthracycline have a significant increased risk of developing cardiac dysfunction. The graph on the right is the Children's Oncology Group guidelines, and they also reflect the anthracycline dose as a factor in determining the intensity and the frequency for each patient. Individuals who receive greater than 250 are recommended to obtain echocardiograms every 2 years. This, however, is a recommendation that a primary care provider may not be familiar with, which is why it's important for each survivor to know the amount that they got and the frequency. Radiation is another type of treatment that can impact their risk. The focus area of radiation impacts the potential late effects. When we think about the focus location, we also need to think about the areas around it because the radiation can potentially scatter and also impact all of those areas around. We know that the dose of chemo and the dose of radiation matter, but so does the combination of chemo and radiation. Many cancers are treated with multimodality approaches, which places them at an increased risk for developing late effects. So if a patient receives both chest radiation and anthracyclines, the combination increases the risk of cardiac dysfunction more than either treatment alone, and the guidelines reflect this recommendation with more frequent screening. Telling our patients this information can be overwhelming, so I also try to educate them while we can't change the treatment they received, we still have things that we have control over. So I really try to focus on diet and exercise and avoiding any tobacco products that can also decrease the risk of cardiomyopathy. Thinking about other factors, what about aging? A study conducted through St. Jude's following childhood cancer survivor over time and looking at the prevalence of chronic health conditions revealed that by the age of 45, 95% of childhood cancer survivors had at least one chronic health condition, and 80% of patients had a serious chronic health condition. This really highlights the importance of lifelong survivorship care because you never know when that late effect could develop. Health behavior, like I said, is an area where I try to empower our patients to take control to limit their risk. There's so much out of their control during treatment and after treatment, but health behaviors is an area where they can make a difference. Not surprisingly, an example of lifestyle choices influencing health is smoking. Smoking for childhood cancer survivors further increases any treatment-related risk of lung injury, secondary malignancy, and heart disease. Sun safety is another area they have control over. The risk for developing skin cancer among survivors who received radiation is 6.3 times higher compared to the general population. Education about sun safety is a key element of long-term follow-up. We also recommend our patients who have a history of radiation to do yearly skin cancer screenings with dermatology due to the increased risk. HPV is a common virus that can cause 6 different types of cancer. HPV vaccine can prevent more than 90% of cancers caused by HPV. Cancer prevention is particularly important for childhood cancer survivors, as several studies have shown that a childhood cancer survivor becomes older, they have a slightly higher risk of developing a second cancer compared to the general population of their same age. A patient's gender, race, and age at the time of diagnosis and treatment all potentially influence the development of late effects. Typically, being younger at the time of treatment increases the risk for certain late effects. Female are also at an increased risk for certain late effects compared to males. As an example of this, younger patients are more vulnerable to neurocognitive deficits after they've received cranial radiation. Oftentimes, pediatric oncologists try to avoid cranial radiations in patients who are 3 years or younger due to the detrimental effects that cranial radiation can have during those important years of development. Patients who have received cranial radiation, it's important to screen for school concerns and neurocognitive late effects. Oftentimes, we see processing speed deficits, so completing neurocognitive testing in these individuals can help them to get a 504 plan and IEP to take back to school so that they can get the extra resources that they need to help them become more successful. Pre-morbid conditions. What are their pre-diagnosis healthcare issues? What are their current ones? As well as what are they at risk for related to their past and present physical status? Are they obese? Do they have dyslipidemia, making them at risk for metabolic syndrome or type 2 diabetes? There are many pre-morbid conditions, including cardiovascular disease, nutritional status, physical conditioning, asthma, diabetes, and dyslipidemia. All of these will play a role in their risk for developing late effects. We also know that the social situation may affect the adequacy of care and support after treatment. For example, a patient who's diagnosed with a brain tumor and receives treatment may develop neurocognitive deficits and mobility issues. If the patient has a supportive family who advocates for the child and accesses all the available resources, it may allow the patient to become pretty independent. But the same patient that doesn't have those resources or the family that's able to get them may struggle and not be as successful as the other individual if they're not able to get their resources. Genetics also play a role in the development of late effects. Do they have familial cancers such as neurofibromatosis, P53, or BRCA genes? We are learning more about this every day, and I really think that the advancements of genetics is probably our future and like the treatment that patients get and will really help decrease some of these late effects. So again, all of this is to say that each patient is unique in his or her related risk related to their profile because the profile is impacted by so many different factors. What are the most common late effects? There's a lot of complexity and detail in the guidelines, but if I were to break it down to the top 5 list of most common things we see, we screen for, or we're asked about, it would include psychosocial, fertility, endocrine dysfunction, cardiac, and secondary malignancies. The psychosocial impacts are incredibly common, and it is manifested in so many ways. It's important to be aware of this and to screen patients for anxiety, depression, and to offer counseling support and social work support. In the past, when we've looked at our referrals, our number one referral was to for psychosocial concerns. Many of these patients can struggle with survivor guilt, fear of reoccurrence, trouble making friends, anxiety, or depression. But we often be told from our patient that appointments can trigger a variety of emotions for them, and it can cause some anxiety. Certain procedures can also cause some PTSD from when they went through treatment. So being aware of this and helping them navigate it is extremely important. In our clinic, we have an embedded psychologist that we've added in the last couple of years who screens for psychosocial concerns with every patient in the clinic. And I'll tell you, the amount of information she gets versus the amount that Dr. Lowry and I get is pretty significant. So I think it's a real benefit to have someone that's trained in that and is able to help them. And then she can connect them with resources or kind of be that bridge while we get them connected with a counselor. Fertility can also be impacted in so many ways. It can be impacted by the radiation, either by when they get cranial radiation affecting that pituitary gland or by their gonadal organs. Chemotherapy, alkylating agents, and heavy metals can also impact the risk for fertility issues. It's really important as a provider, one often needs to start the conversations early, often before the patient maybe is even in a stage of life where he or she is thinking about it, because the referral to reproductive endocrinology or urology is important to preserve options for the patients if they have not undergone cryopreservation during active treatments. Females may be at risk for what's called premature menopause as young as 30, which really highlights the importance for starting those conversations early because some may not be ready to have a child at 30, but may need to think about what they can do if they want to wait till the later years. Endocrine disturbances is also important. Some of the more common endocrine risks we see include growth hormone deficiency, which may result in short stature. This can be impacted from the cranial radiation. And they may require growth hormone replacement. Plotting their growth charts is important for these children in order to identify those that would be at need for that possible growth hormone and referral to endocrine. I always think of one of our patients that was seen more in a rural area that wasn't familiar with the risk of the cranial radiation that he had received. And by the time he had come to us, his growth plates had already closed. So he was no longer eligible for the growth hormone and he struggles to this day with having short stature because once the growth plates are closed, the growth hormone's not going to help you. So I think being aware of that and monitoring it and getting them before that happens is important because being shorter to men especially is harder. The thyroid gland is also pretty sensitive to radiation, whether it's been impacted directly or from the head, which could impact the pituitary. So annual pituitary testing from those is important. DEXA scans can also be something that we look at for individuals who are exposed to cranial radiation, methotrexate, and steroids, just meaning that their bones could be more fragile. So educating them, on vitamin D, calcium, and weight-bearing exercises can help them. I always say the endocrine is a really complex system, and they are way smarter than me. So I think having that referral if you have risk is important. Early cardiac screening is another large piece of what we do in survivorship clinic because so many patients have had anthracycline exposure. We look at their past treatment and educate them on the frequency of their echocardiograms as well as monitoring blood pressures and cholesterol levels. Women who receive higher doses of like 300 milligrams per meter squared of anthracyclines and chest radiation or chest radiation combined with the anthracyclines are recommended to be monitored carefully through pregnancy due to the increased blood flow that occurs with pregnancy because it can cause some extra stress on the heart. It's recommended to obtain additional echocardiogram in the third trimester due to this risk. And educating the patients on the importance of exercise and avoiding tobacco can really decrease their risk as well. Secondary malignancies. Survivors understandably are often frightened about cancer, relapse, and secondary malignancies. Patient factors such as age at diagnosis and female gender are associated with increased risk, as is radiation exposure and several types of chemotherapy, including alkylating agents, anthracyclines, and etoposide. Individuals receiving these chemo have an increased risk of developing a secondary leukemia. If this was to occur, it usually occurs within 10 years from the completion of therapy, which we often screen a little bit heavier in those first 10 years. Radiation therapy places survivors at increased risk for skin cancers, bone tumors, and other malignancies depending on the location of radiation field. So knowing their treatment will help a provider to be able to understand the screening risk for those that are at an increased risk. Awareness of risk for secondary cancer after radiation treatment becomes particularly important when we think about how it changes your cancer screening schedule for patients. As an example, these guidelines-based screenings highlight that for a patient with spinal, abdominal radiation, or total body radiation, that they should start colonoscopies at age 30 compared to 45 for the general population. For young women who receive chest radiation or total body radiation should start mammograms and breast MRIs at age 25 or 8 years after the radiation, whichever's last. These recommendations are earlier than the general population, and a lot of providers are not aware of these screening recommendations. Being overweight and obese has also shown to be linked to many different types of cancer. The cancer linked to obesity and overweight states are on a rise, while other cancers are on the decline. In 1964, the Surgeon General's report on health consequences of smoking. We have tackled tobacco through clinician counseling and avoidance and health policy, and it's worked. Cigarette smoking is on an all-time low, and I often have heard our cancer leaders talk about obesity replacing tobacco as a leading cause for cancer. I often discuss the importance of diet and exercise with my patients as one way that they can take control of minimizing that risk for a secondary cancer. So now what? What should a survivor do to ensure they are receiving appropriate survivorship care? Things we have found are that treatment summaries are really important as it provides the details of their treatment to help providers know exactly what they received so they can get the risk-based screenings. We will provide patients with a treatment summary and continue to follow the Children's Oncology Group guidelines closely. The Children's Oncology Group guidelines, which that's the website and kind of what you see when you Google it, they're typically updated every 5 years. They're about due to be releasing a new version, so some of these guidelines may change in the next several months. It just hasn't been updated yet. But it is a free resource to anybody that would want to access them. I will say they're pretty intense. There's like 300 pages. So it's harder for providers to understand that. This is an example of one of the pages from the Children's Oncology Group guidelines. This particular page walks a provider through cardiac risk related to the chemotherapy one may have received. As you can see, it lists the exposure that places the patient at risk, the potential late effects you need to continue to monitor for, as well as the evaluation that should continue to be completed. Insurance companies are often not familiar with the survivorship recommendations, so this becomes a page that we will send to insurance companies when they have declined the recommended screening for different tests. Echocardiograms are one, sometimes mammograms or breast MRIs are another one that we can then send them this information to get this covered. Requesting a treatment summary is extremely important. This is an example of the treatment summary I completed for one of our patients. On the summary, it includes their diagnosis, when they completed treatment, how they presented, and their past medical history and family history, as well as surgeries, chemotherapies they received, and radiation. We also include late effects that they may have developed. The picture of the charts is an example of the records received when requesting records to put a treatment summary together. We all know that providers could not have taken the time to review the stack of records that they would need to find this information, but they could review a 1 to 3 page treatment summary with the important details. Things we tell every survivor include exercise is medicine. We recommend at least 150 minutes of exercise a week. Healthy diet is critical. We often recommend the Harvard Healthy Plate as a guidance for our patients. Obesity increases the cancer risk, so exercise and diet are extremely important. HPV vaccines help prevent genital urinary and head and neck cancers. Sunscreen is important for everyone, but extremely important for those with a history of radiation. And skin cancer screening with a history of radiation is really important to do yearly for early detection. We have found, just as the literature suggests, that most of our patients do not have a treatment summary or a care plan. As I referenced earlier, it's not unusual for us to request the records for a new referral and receive a pile of charts. And as you know, making it into a meaningful treatment summary document is very time insensitive, but critically important. We here at KU use a software system called Passport for Care, which allows us to put in all the information and then it automatically triggers the Children's Oncology Group guidelines, which are 300 pages, but then it prints out like a 6-page care plan with the recommendations for us. So it's important every time anybody comes to our clinic, they do get that treatment summary, and then we make sure that we have their care plan updated in their chart. So if they go to other subspecialists, that they're able to see that information. So how can the University of Kansas Survivorship Transition Clinic help? We're really here to help however it's most useful to you. We currently see over 200 patients in our survivorship clinic. With some of our patients, we collaborate with their primary care providers and see them yearly for survivorship care, while others we do both survivorship and primary care. Every patient that comes receives a treatment summary, a care plan, and patient education. We also have a pediatric cancer survivorship registry that every patient is eligible to participate in to help learn more about survivorship. So survivorship in general is relatively in its infancy as we continue to learn more about it every day. Because of this, patient partners are important voices of our patients' future. Do you have thoughts on childhood cancer survivorship after today's presentation?
Thank you, Kyla. I am going to open it up for questions. And given the size of the group, maybe we can stop sharing so we can see
Yeah.
everyone. And then people can just raise their hand if they want to go ahead and ask a question. Okay, I see Lori. Oh, teaching middle school cancer survivors. Yeah. Oh, I see Jenny, you have your hand up.
Should I go?
Yes.
Thank you for sharing that. That was really a lot of great information. I did find it interesting when you talked about, I want to say maybe it was non-Hodgkin's lymphoma, maybe patients and developing breast cancer. I knew 2 young ladies that developed aggressive breast cancer after childhood lymphoma. So that was kind of interesting to
Yeah.
hear that.
They often say that it's sometime when you have that mantle radiation, which is basically from here all the way right under your breast, that the risk is similar to that of a BRCA gene. So, which is why it's so important to get the mammograms and the breast MRIs, because if we catch it early, the treatment options are going to be a lot better.
For sure. And this might be premature to ask this, and I don't know how much immunotherapy or targeted cancer treatments are going to be done on children, but it would be interesting to know, and I know there's so many variables with you're growing up your whole life, but it would be interesting to know targeted if there'll be less cancer complications with targeted therapy.
I think that they're starting to look at that because they do use immunotherapy in kids. We just don't know the side effects. I think the proton beam radiation that they use a lot more in kids is going to decrease the risk of different late effects, but that's something, like I said, they review guidelines, the research every 5 years. I do know that they've found they're going to decrease the cardiac screening just because they found that individuals who have less than 100 milligrams are at relatively low risk, so they won't even recommend echocardiograms in the next version. It just hasn't been released yet.
Thank you. Julie, would you like to go next?
Sure. I'm Julie. Hey, I just wanted to first thank Kyla for giving us the information and say you did an awesome job. I actually am a patient of Kyla's clinic. And so my life has been changed through their clinic. So I just wanted to kind of give the other side of someone who has benefited immensely from all of their work. I can't tell you, it's literally been life-changing for me just to have someone keeping tabs on all of the screenings I should be doing. It brings me a lot of comfort to know that I'm being screened, I'm being watched carefully. I travel 6 hours to the clinic. And so, being out here in a rural area and not having access to all of the things out here, just to have it as a one-stop shop and have somebody have eyes on me at that time is just great. So what they're doing is really amazing. And so I just wanted to say thank you for presenting and for all that you guys do.
Thanks, Julie. You're also an amazing patient that follows everything we recommend. So that makes it a little bit easier.
Thank you for sharing that with us, Julie. That's wonderful to hear. Any other questions?
I'm actually curious for Julie's experience a little bit more. Julie, I'm also a childhood cancer survivor, and I actually don't go to the clinic. My curiosity is, there's a lot of great value that Kyla put forward. There is the idea like having a synthesized care plan. Like how many times I have to go over this list of things when I see a new doctor? Like, well, just read the document. That'd be incredibly valuable. Can you tell me a little bit more about your experience and the value that you've gotten from this transition clinic as a patient?
Yeah. So I've been a patient at the clinic, I don't know, Kylie, you'll have to tell me, pretty close to when they started,
I
a
think
couple
it was
years
like 2014 or 15.
Yeah, yeah. I was really struggling in that time frame when your oncologist releases you and then you go to primary care and your primary care is like, I have no idea what to, like, I don't know. What am I supposed to do? They're drawing a blank. They don't know where to send you. Oncology doesn't want to see you anymore because you don't have cancer anymore. So it's just, you're in this gray area of no one knowing what to do. And I happened to see it, I think on Facebook or something, KU's Facebook. So I reached out to them and was able to get connected in, and Kyla did all of the legwork. She gave me the treatment summary. She plugged in all of the treatments that I had. She said, this is, you know, the recommendations. You need the mammograms and you need the echoes and all of the things. And because I come from so far, they're awesome about plugging it into one day typically. So I go, for me, it's every 6 months, but I go one day every 6 months. I get all my screenings done, and then I'm good to go. So they're extremely efficient. Yeah, I cannot say enough things. And we found multiple things kind of along the way, but I feel like they've been small things because we've found them early. We've dealt with them. I have a team. I know where to go. So it's just, it's been invaluable and literally life-changing. So yeah, you should definitely reach out.
Thanks, Julie. Well, I appreciate it. It gives a better understanding. Hey, this is you get a whole team approach. We're gonna go there for a strong debrief of your health, and we're gonna pack all these great information in one day. And so that's very helpful, especially because I don't live in Kansas City either. So I'm not I am from Wichita, so it is what it is. But that is very helpful for patients and getting that perspective, making sure that we are time considerate of all those needs.
And
So
I think a lot of times, I was sharing with Kathy before the presentation started, is a lot of times when you're leaving a children's hospital, you kind of feel like you're in good health and you don't necessarily need to go to a doctor. I was like that in college, but I think especially for patients who have been through something significant, it's important, which is kind of why I go to Children's Mercy, because I basically transition them over to KU. I call them in a year. They don't call me because they may not, or make it lost in follow-up if I didn't do that. So it kind of helps with that.
They're also really great about working with your primary care provider, or, getting screenings done locally there closer to home. That's definitely an option as well. And then any specialists that you need, they will refer you to those and set you up with those. And so it's just a good central hub, I guess, of information.
And with being in Kansas, another option, if it is something you want, we can do telehealth and then refer everything back over to your primary. So to staying local, that's another option that we've done.
Super helpful. I love the accessibility, especially as we kind of think of, just think of the state of Kansas. Kansas City's that very tip, right?
Yeah, and I think we've had patients from, I want to say when we looked at it last time, it was 40 different counties and multiple different states. We even had one patient travel international once. So we've had patients from all over.
Wow.
Does the international, do they keep coming back? Maybe not too much information.
This patient, originally was from Kansas City and they came back, but had moved over. So come back for follow-up.
That makes sense. Perfect. Thank you for that.
Any other questions or comments? Okay, well, I want to thank everyone for their attention. I want to thank Kyla for coming to share all of this great information with us, and also to Julie for sharing her experience. This has been great. So thank you all, and have a great rest of your day. Take care.
Perfect. Thanks all. Feel free to reach out if you have any questions.
Thanks, Kyla.
All right. Thanks. Bye.